So for those that don't know my background, I've been involved in ophthalmic lasers since the late 90s. So SLT lasers, Pascal, Visidyne, femtosecond, cataract, are all things that I've been involved in from the very beginning and invented many of those. This actually follows the experience of femtosecond cataract and basically looking for a more economical approach that also could provide benefits in complex cases and also just work with the workflow, so not to take up so much spaces, resources, electricity, and everything else that we just heard about in the green revolution that we're all going to have to face. This is real time. These are capsulotomies that take a third of a second. So why should we consider capsule laser over other technologies? So first, it is superior for complex cases. So we can see this in intermittent cataracts, pseudoexfoliation, pediatric, and we can go on. The high tear-resistant edge really transforms the capsulotomy over other technologies, such as manual or femto. This is much stronger, and I'll go through this. The trypan blue needs to be present because the laser interacts with trypan blue. When we did femto, the capsule is clear. When we do manual, the capsule is clear. And the way that I made capsule laser work was by just saying, let's look and see what Dork did, and we can do better, and our dye is indeed better. But now, once it's stained blue, we can now actually create an orange laser to interact with that. And then we get the visibility throughout. We'll touch briefly on centration. And then for my colleagues that are in the Eastern Europe that see a lot of intermescence, they're reporting back, they have seen Argentinian flag sign disappear. 0. I'm sure we're going to find it in India because we see very much more mature eyes. So I'm going to say minimal occurrence of Argentinian flag sign. And the real benefit is that we are non-invasive with the laser. With premium lenses, or in fact all IOLs, we actually can see improved outcomes. And how can this be the case? If we get complete symmetric 360-degree coverage of the IOL with the capsulotomy, our effective lens position is exactly what the biometry calculations are showing. If we are asymmetric, or if we are not got 360, then you could throw your biometry out or add some unpredictability to it. So by having 360 coverage, we're seeing incredible predictability in uncorrected distant visual acuity. And I'll show you some of the initial results on this. Finally, we all know that fellows find it hard to pick up the technique of manual capsulorhexis, and we can actually do, by design, a partial capsulotomy that then a fellow can come along and now engage in the technique, and then also has that hard, strong rim as a safety net, and then if you go outside of that, then everything's trypan blue. So there's many potential advantages. So let's go through these 3 different scenarios. So the strong capsulotomy edge, we see a cadaver eye here, lens capsule. The dark blue edge is indeed the capsulotomy, and we can see it stretched almost what would be white to white. If we look at the strain gauge calculation here, we can see that 5 millimeter capsulotomy is stretched to 12, but if we were doing before it ruptures, but if we were doing manual, it would only stretch to about 10. So these are the strain gauge curves that are based upon the measurements. We can also see this in vivo, in the OR, in real live eyes. This is Burkhart Dick. And then basically, we see the relative strengths that are reported in the journal, British Journal of Ophthalmology. And what is this dark blue edge that gives us the strength? This is a scanning electron microscope that shows the rolled over edge that gives us the strength, very much like we have with clothes. If we have a rolled over edge or a hem, then it basically does not show a defect, and so therefore it's inherently much stronger. So this is what we want to avoid. Why does Argentinian flag sign occur? Because there's contact. The other great thing with capsule laser is that we can have OVD in the anterior chamber so that we can counterbalance pressures, so we can use all the great techniques that are out there. We don't have to make an initial small capsulorhexis. We can just come along with a laser and then basically create very nice capsulotomies. And you see the difference in sizes here. This is because there's a high pressure. Let's just go through a couple of extra ones from around the world. This one's from Spain. This one is from Saudi Arabia. We'll go through this a little slower. You can see the incision is actually very small where we make it, but it opens up with the pressure that's involved there. And then we'll go to the, just a moment here, we'll jump to the phaco after we slide the laser out. And what we'll see is the eye has a lot of milky fluid there, and as we come along, we can aspirate that away, showing that truly was the pressure that was built up there, and a very intermescent cataract. And as we know, the nucleus is not so hard once we've dealt with that pressure and the thin tissues. Now this is from Brazil. We basically, very similar, intermescent cataract. And you can just peel off the capsular disc. Now, interestingly, here we say, oh, there could be some bridges, but no, there's actually fibrosis occurring underneath the capsule. We see that because we have the trypan blue stain. And so now we don't get surprises when we're doing phaco, and we can now just come along and just peel this off, or try to peel it off, and decide, and again, the strong capsular rim helps us here because it adds a lot of strength. So something that, and now this is just a normal cataract, so we wouldn't have any issues there. Pseudo-exfoliation patients, small pupil, thin tissue. We can just dial in the size of the capsulotomy as needed, or use pupil expanders. Again, we have access to the anterior chamber to really maximize the pre-capsulotomy conditions. I have a minute left, so let's go. Pediatric case, just to show you. As we know, they expand, so we can cut at 4.2, but we see rather large expansion up to 5. So let me just put it this way. 4.5 gives you 5.2 millimeter diameter. So you want to cut a little small, but not 80%. Probably around 85% is where we see with pediatrics. So this is what we'd all like to see in premium cases, but we may be able to see that in all cases. We can see the Purkinje images where the patient's fixated. We see a dark area actually centered on those Purkinje images, and that's a trypan landmark. And then we see the capsulotomies below. If we center on the Purkinje image or that dark blue area, the trypan landmark, we get excellent centration. And we can see this is verified by Zeiss-Callisto overlay reference to the IOL master data. So we see excellent correlation on the central axis, and that central axis seems to be key to giving us great centration of the IOL in vivo. And if we compare it to Victus, we can see that some of the femtos are not, let me just say this, not all femtos are the same, and I've developed some of them, so I know. And I'll actually say Catalyst is very good at centration. But we know Victus and Lens X may not be so great. And for example, in this image down here, we can see that we are asymmetric, and we probably actually have zero coverage over here. And that's going to be a tilted lens, and you can even see that in the Purkinje images on the lens. Very interestingly, if we now look to how predictable the distance visual acuity is, we can see if we compare asymmetric coverage of the IOL to symmetric, we actually see here, in this column here, a difference in uncorrected distance visual acuity for the same eyes. Yes? Okay, it's all right, I'm nearly done. I've got 0 time left. For the next speaker, maybe. So here we see an anterior fixated capsulotomy basically occurring. So again, capsule laser, very robust capsular rim, can be manipulated very easily. And so here we see, as I said, an anterior capsule fixated lens, or a femtus lens in this case. And there are several other companies coming out with this. The anterior position of those IOLs removes some dysphotopsia. And of course, having it centered in a robust capsulotomy of the correct size and circular is critical. And for example, in Australia, we are 100% of the largest femtus lenses being used, and we are in every single OR, and they're all created without laser. Just to show you the idea of accelerating manual capsular access training, this is by design. So we actually use the same laser, same setup. We use a different OVD. This OVD will actually scatter the light a little bit more. And what we can see here is that there are bridges, but it's relatively consistent. And it's actually only about 20% remaining of the capsule. 80% has been essentially separated. So now, this will be great for a fellow to come in and do training and basically move forward and then just manually, after doing their OVD fill with their preferred OVD, you can now just come along and just manually do a rexus, and it's going to be great for training. And you have a strong rim if they go a little bit too aggressively, really working on the tangential motion rather than the radial motion. And just to summarize, superior for complex cases. The strong rim and visibility really enable that. Premium lenses, the predictability comes about from the 360-degree coverage, and that really goes to all the biometry calculations, and then accelerated training for manual. So that's why and where we can use capsule laser in cataract surgery. Okay, thank you.